Good morning, everyone. I'm John Hirdes. I'm a professor at the School of Public Health and Health Systems here at the University of Waterloo, and I'm the chair of the Committee on Student Mental Health at the university. I'm delighted to welcome you to our first conference on student mental health research, which will be happening over the course of today. This is an event that'll be recorded, so it'll be available to people after the fact, and it's a virtual event, so we'll have people joining throughout the course of the day. We've got about 16 different presentations and 14 poster sessions, and over 260 people registered for the event. So we're delighted to be able to kick off this first conference on student mental health research, which I hope will be one of many in the future. This conference is a response to the President's Advisory Committee on Student Mental Health, which the Committee on Student Mental Health is charged with implementing. And there are two specific recommendations that this conference relates to. Recommendation number 35 is one that calls for establishment of an initiative related to student mental health research on campus. So this is a kickoff event for that recommendation, where we hope to build capacity over time to have a vibrant program of research related to student mental health on our campus. And then recommendation number 14 deals with starting a dialogue on a campus-wide basis on a variety of different topics, all of which were used to identify themes for today's research conference. So I'm delighted that you're able to join us for this event that is a direct response to the great advice that was given in the President's Advisory Committee on Student Mental Health Research. I do want to mention to folks that over the course of the day, we'll be dealing with a variety of different topics related to student mental health, and some of those topics may be difficult to discuss. And so I want to remind everybody that there are support resources available to staff, faculty, and students on campus. I think we have a slide related to those support resources in a couple moments. So if you do need some help, do reach out for counseling services or Empower Me. We also have an employee health and family assistance program for mental health services. The university is very committed to mental health of its students, staff, and faculty, and the broader community. So if you feel the need to reach out for some of these resources, please do so. At this point, I'd like to welcome the University of Waterloo President, Feridun Hamdalapur, to give greetings and to open the conference and do our land acknowledgement as well. So Feridun, if you're there, please join in.
Yes, John, of course. I wouldn't be anywhere else for this conference, and thank you so much. I wanted to thank you and the team, and also members of the Committee on Student Mental Health for their absolutely great work, and also for organizing this conference. But before I start, it's a tradition and imperative that we start every event by first paying respects to the elders of past and present of the neutral Anishinaabe and Haudenosaunee peoples. The University of Waterloo is situated on their traditional land, the Haldimand Tract, the land which was promised to the Six Nations people that extends on each side of the Grand River. As I said, John, I'm really grateful your effort, but many others for seeing, understanding, and taking action on this extremely important challenge issue that we are facing. Many years back, we could probably remember that on many university campuses, the term mental health in general and student mental health specifically was completely avoided just because it was simply inconvenient or there was nothing to do about it. And in some cases, there was a level of discomfort even to admit that one could be going through this experience. I'm very proud that today the University of Waterloo has taken definitive actions through various means, but first and foremost, we put our students first. Their overall well-being is extremely important. We want them to be academically very successful. We cannot even imagine for this success without incorporating the overall well-being and specifically the mental health of these students. Since after a number of experiences, the university decided that it was time for us to do a full scan, to go as deep as we could in this subject and properly establish whatever was required and start working on this. I was delighted with the level of participation of many people, staff, faculty, students, people from outside of our communities, their willingness to come and be part of identifying issues and be part of the solution. Today, I'm also very proud that 92% of all the recommendations that were made this committee by this committee, they have already been implemented, and there are some that we are working on. As delighted and as proud as I am in giving you these details, I also fully recognize that we have a lot more work ahead of us. I will not just sit back and say that, well, look, we've done a lot of things. I think we have completed this issue. I would be very mistaken, and I don't think that will be the right thing to do. John's leadership has been phenomenal. Many others. We will count on so many passionate individuals who understand this issue and also refuse to be on the sidelines just watching what others will do. We are working on this together, and I believe that together we will be providing a much better supportive environment to our students. As we are going through the COVID-19 pandemic, it becomes more and more evident that as human beings, we're vulnerable. Many of us are going through just new, whatever it's called, the new normal, that ranging from isolation to wondering about what tomorrow brings, and to the enormous different type of workload that many of us, but especially our students, are facing. So I'm grateful that, John, we have this conference today. I looked at the program. It is an unbelievably rich agenda, and I believe many of these things will be covered at the end of this conference. I think we will know more, and we will be even more determined to continue taking action. Thank you so much. I wish you a very productive, great research day.
Great. Thank you very much, Feridun, and thank you as well for the leadership you've shown all along as president of the University of Waterloo. It's been very gratifying to have your full support as well as all the support of the university leadership from the Board of the Governors down. And it's also been gratifying to see how the commitment to supporting student mental health really permeates all aspects of the university at all levels and all members of the community. So we're delighted to have such a strong commitment in this university. So thank you for taking the time to join us. As a procedural note to folks, I want to be sure that you know about our poster sessions. We have poster sessions that have been pre-recorded throughout the conference, and 11:15 we'll have a live Q&A session for our poster session presenters, so please do join us for that as well. So to kick off the conference, I'd like to hand over to Dan Brown, who was one of the founding members of the Committee on Student Mental Health, to introduce our first session. So Dan, if you could take over from here, that would be great.
Sounds great. Thank you, John. Good morning, everyone. I'm Dan Brown. I'm a professor in the School of Computer Science at the University of Waterloo. I'm also president of the University of Waterloo's Faculty Association, and so I bring greetings and encouragement on behalf of Waterloo's 1,400 faculty members. Thanks so much to John for his leadership of COSM, and also to the university for taking a really important societal problem very seriously, and really, what's better than a day talking about research? This first session is a session about harms reduction and substance use in university-age populations. We have two papers today, just to give a sense of format, and I think this will go on for a lot of the research sessions today. The way that this will work is we'll have two 10-minute presentations from two presenters, and then after that we'll have a Q&A period. Audience members, if you want to provide questions, you can do that in the Q&A function of Teams Live, and then I will see them, and then I will publish your question, and then I will read your question to the presenter. I hope that's a thing that at this point has become regrettably familiar in the pandemic period to a lot of folks, but that's the procedure we'll be following today. So with that, I will actually, John, we're just a touch ahead of schedule. Do you want me to? We're supposed to start the actual presentations at 9:15. Do you want me to riff for a couple of minutes, or you're mute?
I think we're okay to start.
Okay.
If you want to tell some computer science jokes, that's always welcome. I think we're good to get started.
Okay. It's all one of the other funny things about running these conferences online in the COVID era is that keeping to schedule is both very obvious and also still just as challenging as ever, and that's why I asked the question. So thank you, John. All right, so I'll quickly introduce the two speakers in this morning's first session, and then I'll change things over to them. The first presenter this morning is Jennifer Rupp. Jennifer is a master's student in public health at the University of Waterloo. She's studying cannabis policy and cannabis use, and how legal and illegal markets for cannabis differ in who makes use of cannabis now that it's legal here in Canada. She also focuses on cannabis use and its interaction with mental health, and that's the focus of her paper this morning, which teases out how specific mental health conditions intersect with cannabis use patterns and how this also might affect harms reduction plans. So that's our first speaker, and then after Jennifer Rupp, we'll have Dr. Oluwakemi Aderibigbe. Dr. Aderibigbe is a PhD student in public health at the University of Waterloo. She's also a public health physician. She has about 15 years of experience in that field, including, and I found this sort of fascinating in reading her bio, development of mental health supports for people who have survived armed conflict. Her PhD research is focusing on providing mental health supports for marginalized and vulnerable populations, including youth and with substance abuse and mental health conditions. Her paper this morning is similarly on these questions of adolescent substance use and mental health, where she's also studying social conditions that connect to this relationship between these two phenomena. So I think with that, I'm going to turn things over to Jennifer Rupp. Jennifer, if you can take the floor, we'll have your 10-minute presentation.
Sure, thank you, Dan, for the introduction.
Awesome.
Okay, can everyone see the slides all right?
I can see them.
Perfect. Good morning, everyone. So today I'm going to be talking about cannabis and mental health and discussing the prevalence of use, product types, and adverse outcomes by mental health status in Canada and the US. So just for some brief background, there are many different factors that can contribute to poor mental health or the risk of developing a mental illness. And among these, there's the use of alcohol or recreational drugs. We know that there's a link between substance use and mental illness. They're highly comorbid, and there are a few different theories as to why there's such a strong relationship between the two. Predisposing factors, along with environmental factors, could increase an individual's vulnerability to addiction or substance abuse. And alternatively, some consumers may choose to consume substances in order to self-medicate symptoms of the disorder. So research has actually shown that youth aged 15 to 24 are more likely to experience mental illness and or substance use disorders than any other age group. So now when we're looking at cannabis specifically, cannabis is the most widely used drug in the world. And again, youth have the highest rate of use compared to other age groups. There are adverse effects associated with cannabis use. Some acute effects include confusion, impaired concentration, anxiety, among others. And there are also chronic effects such as the impact on memory, concentration, intelligence, and potentially increasing the risk of developing cannabis use disorder. There are also some potential therapeutic effects of cannabis, although there's scarce evidence to support its effectiveness for treating mental health disorders. So when we look at the effect that cannabis has on mental health, it really depends on a number of factors, including the age of initiation, frequency and duration of use, dose and potency of product, individual and genetic differences, as well as family history of mental illness. And when it comes to the association between cannabis use and the development of certain mental health disorders, we see that there's mixed evidence for anxiety and depression, limited evidence for bipolar disorder and post-traumatic stress disorder, although evidence does show that cannabis use can typically worsen clinical outcomes for these disorders. And for psychosis, there's a substantial amount of evidence indicating the risk of earlier onset of the disorder, as well as increased symptom severity and poorer prognosis. So for my thesis, we conducted 2 studies looking at these 5 mental health conditions in particular in relation to several cannabis-related outcomes. The first study looked at the prevalence of cannabis use and types of cannabis products used among consumers with and without a past 12-month experience of anxiety, depression, PTSD, bipolar disorder, and psychosis. So with the current market, there's an increased availability of cannabis in different forms, including increased potencies of different products. And we know that high potency products, which are products with a higher concentration of a chemical called THC, can increase the risk of adverse outcomes. So it's important to assess cannabis product preferences among vulnerable populations. So for this study, data came from Wave 1 of the International Cannabis Policy Study, which was conducted from August to September 2018 through online surveys in Canada and the US with participants aged 16 to 65 at recruitment. And this study had approximately 25,700 participants. The measures that were used for the studies are outlined here. So multinomial logistic regression models were used to analyze the frequency of cannabis use, and binary logistic regression models were used to look at differences in past 12-month use of each of the 9 product types that you see here. And all models were adjusted for age, sex, ethnicity, education, and country. So what we found was that apart from psychosis and the use of vape oils, compared to consumers without any conditions, those who experienced each of the 5 conditions in the past 12 months were more likely to use cannabis concentrates, hash, and vape oils, which are actually the 3 most potent product types out of the 9 products on our list. And so there are a couple of reasons why this might be the case. One is that consumers may purposely select higher strength products for greater symptom relief. Or through frequent cannabis use, consumers may actually build tolerance over time, and then they might seek out higher strength products in order to maintain the desired outcomes or intoxication levels that they're looking for. So in addition to this finding, we also found that those who experience a mental health condition are more likely to report more frequent cannabis use, which is a finding that we see in existing literature, because we know that cannabis use is 2 times as common among those with mental health conditions compared to the general population. So overall, this trend is concerning because of all the evidence that we see for high potency cannabis and its association with poor mental health outcomes, particularly for those with psychosis. So the preference for these products does warrant greater attention. In the second study, we looked at differences in past 12-month medical help-seeking behavior, as well as the use of cannabis to manage or improve symptoms of mental health, and perceptions of positive and negative effects of cannabis use on 7 different categories, including friendships, physical and mental health, family life, work, studies, and quality of life. Again, data came from the International Cannabis Policy Study, and this study had just about 5,700 participants. These were the measures that were used for study 2. Binary logistic regression models were used to examine differences in medical help seeking, as well as the use of cannabis to improve symptoms of each condition. And multinomial logistic regression models were used for each of the 7 categories related to perceived impact of cannabis use. and each category had 3 levels which were positive, negative, or no effect, and all models were adjusted for the appropriate covariates. So what we found in study 2 was that past 12-month medical help seeking was greatest among those with psychosis, bipolar disorder, and depression, which is unsurprising given all the evidence that shows that cannabis can increase symptom severity for individuals who experience these conditions, particularly for bipolar disorder and psychosis. We also found that use of cannabis to manage symptoms of mental health was pretty high across all 5 conditions, and highest among those with bipolar disorder and psychosis. In addition, there were a few other key findings in the study. The reports of positive effects of cannabis use were substantially higher than negative effects across all of the categories, except for mental health, where consumers who experience each condition consistently reported negative perceived effects on their mental health. In addition, consumers with psychosis were most likely to perceive negative effects across all of the 7 categories. And those with anxiety and PTSD were more likely to report negative self-perceived effects on studies. And this actually sort of aligns with some previous evidence which suggests links between heavy cannabis use and reduced educational attainment. In summary, there was greater help-seeking behaviors, self-perceived negative effects, and use of cannabis to manage symptoms among those with psychosis and bipolar disorder. Consumers consistently rated cannabis as having a positive effect, but were also more likely to seek medical help related to the negative effects of cannabis use compared to those without a condition. Those who experience mental health conditions report more frequent cannabis use and greater use of more potent forms of cannabis, which actually shows a clear discrepancy between public health warnings, such as the ones that Health Canada put out against the use of high potency products and mental health, and consumer behavior. To tie it all together, the study sort of emphasizes or highlights the following points. 1, the relationship between cannabis use and mental health is complex, disorder-specific, and may include a combination of perceived benefits as well as harms. The risks related to cannabis use are worse for those who experience psychosis compared to other conditions. And finally, there is a critical need to test and target the use of specific high-potency products in prevention, treatment, and harm reduction among people with mental health conditions. Acknowledge the funding for this project, and thank you for listening.
Wonderful. Thank you, Jennifer Rupp. That's very interesting. We will have a Q&A after our next speaker. And so if you have questions, please supply them in the Q&A window of your Microsoft Teams installation. But with that, I will move on to our next speaker, which is Dr. Oluwakemi Aderibigbe. Please go ahead.
Good morning, everyone. I'm Oluwakemi Aderibigbe, and this morning I'll be talking about characteristics of Ontarian youth in mental health settings who use substances. And this is part of my PhD research project. Mental health is an important component of health that affects all aspects of life. This is what we've all been saying. And about 70% of mental health problems have their onset in childhood or adolescence. And previous studies have consistently shown that psychopathology is linked with adolescent substance use. In 2012, about 1/3 of Canadian youth reported having co-occurring mental health and substance use disorder. Mental health and addiction-related service use among young people in Ontario has been increasing over time, with about 1 in 5 children receiving the needed mental health services. However, limited studies have used representative data to examine the prevalence, pattern of use, social and clinical correlates of substance use among youth in mental health settings in Ontario. Research around adolescent neurodevelopment suggests that adolescents' brain may be more vulnerable to the effects of substances. Hence, they are at risk of developing patterns of behavior that result in substance use disorder. And in general, factors contributing to increased likelihood of substance use among youth can be broadly categorized into individual, familial, social, and environmental factors. So with so many potential causes, the concept of substance use disorder and the relationship between substance use and mental disorders have been explained by many theories and hypotheses. Like the gateway hypothesis suggests that adolescents' early experimentation with illicit drugs like alcohol or tobacco escalates to more addictive use of illicit drugs later in adulthood, because the use of one drug enhances the effects of the other drugs, especially during early and mid-adolescence. The biomedical model view addiction as chronically relapsing brain disease with genetic and biochemical cause, and this model views other dimensions of addiction like social, psychological, and behavioral as less important in the etiology and treatment of addiction. Also, many explanations have been proposed for the increased risk of substance use disorder and among people with mental illness. The secondary psychiatric disorder model posits that substance use contributes to the onset of mental illness, while the secondary substance use disorder model proposes that serious mental illness increases the person's chances of developing substance use disorder. The common factor model posits that risk factors are shared across both substance use and mental illness, and the bidirectional model hypothesizes that either substance use or mental disorder can increase the vulnerability of the other disorder. However, evidence shows that a single factor cannot explain why some people are able to use substances without progressing to addiction, while others become dependent on substances. Therefore, the biopsychosocial model explains that the biological, genetic, personality, psychological, cognitive, social, cultural, and environmental factors all interact to produce substance use disorder. The biopsychosocial model also connects all other conceptual models for addiction as well as model for co-occurring substance use and mental health disorder. Outcomes of substance use for young adults are numerous, affecting various aspects of life. For instance, a study that examined the association between substance use and academic performance shows that past year users of substances had 2.7 greater odds of skipping school and 1.7 greater odds of having low grades than lifetime non-users. Lifetime non-users also reported greater academic self-efficacy and emotional academic engagement than past year users. And another study that examined the association between level of cannabis use at age 14 to 21 years and life outcome at age 21 to 25 years found that those that never used cannabis are more likely to gain university degree by age 25. They are more likely to earn more income, less likely to depend on welfare, and less likely to be unemployed. They also reported better quality relationship and life satisfaction. Other consequences of substance use among youth include transmission of sexually transmitted diseases, involvement in crimes and violence, social isolation, depression, just to mention a few. And among those with co-occurring substance use and mental disorders, substance use has been found to interfere with and complicate treatment for mental health disorder. Substance use also worsens outcome and long-term prognosis of mental illness. For instance, review studies show dose-related increase in psychotic symptoms, violent behavior, suicide fatalities during periods when amphetamines were being used. So the purpose of my PhD research is to examine the social and clinical characteristics of Ontarian youth living with co-occurring substance use and mental health conditions based on their level of marginalization. And research question 1 examined the characteristics of youth in mental health setting, comparing those that use substances with those that did not use substances, using a province-wide data. The methodologies for the 3 research questions are summarized in the table. And research question 1 is a retrospective cross-sectional study. Sample was drawn from youth aged 12 to 18 years who have received care in mental health agencies in Ontario and assessed with Interact Child and Youth Mental Health Instrument. I'll present some of the results of my first research question, but in summary, factors that are significantly associated with co-occurrence of substance use and mental health condition among this study population include age, risk of disrupted education, relationship, and some other social factors. As we can see on this chart, prevalence of substance use among male is not significantly different from female. And substance use prevalence increase with increasing age. Prevalence is 4% among 12 to 14 years, and 38% among 17 to 18 years. Prevalence of substance use was also higher among those living alone and those with history of stressful or traumatic life events. Prevalence of substance use was 27.9% among those that reported hyperactivity symptoms, compared to 19.6% among those with no hyperactivity symptoms, and 22.8% among those that reported negative symptoms, compared to 13.4% among those with no symptoms. Prevalence of substance use was also higher among those with behavioral symptoms and those with history of self-injurious ideation or attempt. Substance use prevalence was 17% among those that have strong and supportive relationship with family, compared to 33% among those that do not. This makes strong family relationship a protective factor. Those at risk of disrupted education have higher prevalence of substance use compared to those that are not at risk. And the most used substance among youth in Ontario is cannabis, followed by alcohol, then misuse of prescription and over-the-counter medications. This table shows that young people that use substances are more likely to trigger anxiety, depression, hyperactivity, and CHAM skills compared to non-users. This means that higher proportion of those that use substances have mental health issues significant enough to require urgent mental health services compared to non-users. And implications for students. It's important for students to be informed about the risk and protective factors, as well as consequences of substance use and mental illness and the relationship between the two. Also, being a university student is stressful, but it's important for students to know that there are alternative ways to manage or cope with stress that do not require substance use. The university and health services should provide adequate safe spaces for students to openly talk about substance use and mental health issues. In health services, mental health assessment should include substance use assessment, and substance use should be considered within mental health treatment. So in conclusion, evidence has shown that most mental health conditions and substance use have their onset early in life, and the association between substance use and mental disorders have been established. Therefore, prevention programs and services for substance use and mental health should be integrated and provided at first presentation of illness. This will enhance the development of an effective treatment plan to address the needs, as well as curb the trajectory of mental health and substance use problems among young people. This is a reference list for some of the literature review for this study. And that brings us to the end of my presentation.
Wonderful. Thanks very much. If you have questions, please put them in the live Q&A on your Microsoft Teams installation. I'll probably spend a few minutes asking my own question because we don't seem to have a lot of listener-supplied questions. So I'll start off with a few questions from the two studies. Thanks very much. These were both really interesting to me, and I'm fascinated by these questions of how to understand the relationship between self-medication on the one hand and perhaps a causative function of substance use towards mental health conditions on the other hand. So I think I want to ask maybe both of you various versions of the same kind of a question. Dr. Aderibigbe, you talked about the secondary psychological model and the secondary substance use disorder model as basically a question of where the causation arrow goes in that relationship. And then you went forward and said that maybe the right thing is to just think about everything as a big mass. Is it possible, let's suppose we were just taking these two alternatives. Is it possible to imagine an experiment that really gives a good answer to those two possibilities of chemical use, substance use is caused by disorder versus substance use causes disorder? When we think about, maybe I would just go back to the model, right? Saying that it's one thing that leads to the
occurrence of another thing. Let me say, it just comes down to that, like the egg and chicken story, right? And also because, like the biopsychosocial model tries to explain, it's not just one thing that is the cause. We can't say that this is a single factor that is causing either substance use or mental or addiction in people, for instance. So we could try. I know that many studies will have also tried to look at this, but it's just because of many other factors that contribute that could be. So we cannot really say this is one single thing that is leading to mental illness or to addiction in people. I don't know if Jennifer has something.
Yeah, I have a sort of parallel question for Jennifer, but if you want to actually address this one as well, I'm delighted to hear your thoughts here.
I think that's a great answer. I would agree with that. Yeah.
Awesome. I guess my question for you, Jennifer, that's somewhat related is you talked a lot about self-medication and how that doesn't seem to actually work. In fact, people who had mental health conditions and used cannabis had worse outcomes than people who didn't. And yet there's this tremendous popular understanding that pot is a great drug if you've got anxiety or other mental health conditions. What's going on there? Why hasn't the negative outcomes that people like you are identifying made it into the popular media very well?
Yeah, so that's a really great question, and it is, I guess, a bit controversial, depending on who you ask. But basically, what we do know is that the strongest evidence comes when for conditions like bipolar disorder and psychosis, and because the evidence is so scarce or inconclusive for conditions such as anxiety or PTSD or depression, you can't really say definitively that it does have an adverse outcome. And then what we did see as well in this paper, which was very interesting, was that people were more likely to report positive effects across different areas of their life, such as families, like social life, friendships, and things like that, but then would consistently rate negative effects for their mental health. So it shows that—
that's interesting.
There's a combination of benefits and harms there, yeah.
I see. So their day-to-day life might be better, but in fact their mental health is worse or something. I mean, it's a weird thing. Like my day-to-day life is bad when my mental health is bad. But yeah. Okay.
It's interesting.
Thanks. We have a couple of questions that have started to come in. One question, which is for you, Dr. Aderibigbe. A person asks about caffeine intake in mental health, and that's not so much in your study, but I'm wondering if you know anything about maybe that or other drugs that people might be using that are legal and popularly taken care of.
Yes, so like the inaugural assessment instrument that I used for this study, also there are questions around caffeine, alcohol, and tobacco, and these are some of the listed drugs that are discussed in the gateway hypothesis as some of the things that people start using earlier, and we also found that those that use how do I say no? I did not check actually the prevalence by substance use, but we know that youth also use a considerable proportion of youth use caffeine as well.
Sure.
In this study, yeah.
Sort of a similar question that I noticed when you were showing your charts was that there were a lot of people who were using, that there were many more people in your study who were using cannabis than alcohol, which, I mean, maybe it's just that I'm old, but my impression was always that young people were certainly using a lot of weed, but that they were also drinking a lot. And your study seems to indicate that cannabis use is much more common than alcohol use. Do you know when that transition may have happened, and can you speak a little to the mental health consequences of that?
I'll say that like worldwide, cannabis use is one of the most used substances among this particular age group. And one thing that might be contributing to this spike that we are having in Ontario could also be the legalization of the cannabis use for recreational use of cannabis use. So, and just as Jennifer has said, and as with many other substance use disorder, like consequences of substance use, we expect that it complicates, apart from the effect on academic performance, like I've shared in my presentation, we also see that cannabis use has been found to be associated with worse treatment outcome for these people, and also with some mental health symptoms, like I showed, violence, even suicide or ideation or the attempt. So these are some of the, it's similar to what we see in other substance use as well. Yeah.
Okay, thanks. Jennifer, did your study look at other chemical uses besides cannabis, or like say alcohol, or was it primarily just on cannabis?
It was just on cannabis.
Okay, sure. Both question for both of you. I guess this one's from John. What are the public health strategies that make sense for reducing youth substance use?
Yes, so I think some of the common ones would be, a big one is age of initiation. So really, young people are under the age of 21, I suppose, because that's, or 18, the age of legalization in many provinces, really shouldn't be starting cannabis and using frequently. So age of initiation, frequency of use, because we know that more frequent chronic use is associated with negative outcomes, as well as the use of high potency products. So products that have higher concentrations of THC are also associated with many negative outcomes, especially with relation to mental health, especially for people who experience psychosis.
Right, and you can't really predict that in an adolescent who might be starting to use at 14 or something. So
no, although research does show that it does increase the likelihood of developing into adulthood.
Right, but for an individual person, it's hard to say you shouldn't and you should, for example. Right. Yeah, that's really important.
Yeah, I agree with Jennifer, and I also think it's also about taking a broader approach to the control rights, like starting from schools. I think partnering with school or working through school is a good avenue to also target students, as in from elementary school, start teaching them and creating the awareness about the consequences, because I think it's important for them to know the consequences of substance use and how it can affect their academic performance as well as mental health and other aspects of their life. So school is, I think, is important target to work with. And also it's about addressing those broader social determinants, which are larger, because we found that there are a lot of social determinants are very significant predictors of substance use among these people. So it's taking into consideration all those broader dimensions of substance use and mental illness. So
yeah, I was interested at the end of your paper when you said that university and other school mental health providers need to be talking about things that aren't proposing alternative ways for people to manage their mental health challenges than relying on substance use. How do you think that's changed since cannabis legalization in Canada has become a thing? I mean, it's hard to message that you shouldn't do something that society has actually moved in an opposite direction in its control strategy. Basically, what I'm asking is, how do you get that public health message out about alternative to substance use when the legal framework is actually moving in the opposite direction?
I think if we can demonstrate the effectiveness of what we're proposing, I mean, we learn every day, right? We make decisions, we keep improving on them, on policies. So if we can show that when people openly, and when I say create space for open discussion. It's for people to be able to come out, to feel free to be able to come out, so that even when they notice that they're having maybe problematic use of substances, it's easier for them to speak out about this and to seek help. That is what I mean by creating space for that kind of discussion. And for the health services, it's also about integration, right? So that we are able to identify those that are having this issue earlier in life before they even progress to more complicated issues. So it's about when someone comes with mental health issues, we are also able to assess for substance use, and we are able to, whatever intervention we think will work for that person, we are able to integrate that into the treatment as well, as early as possible. Yeah. Okay.
I think the last question we'll take is from Tasneem Khan, who's a PhD student in the same department as you two. She says, this is for Dr. Aderibigbe, she says, there's no statistical difference in cannabis use among the two genders, but there still might be a series of substance use that are different for women than for men. Is that true in practice, or is the same sort of model used for both?
Yes, so I think that's a very interesting question that has come up, and the classification, it depends. Like for this study, defining substance use, it's a close like misuse of prescription drugs and over-the-counter drugs. So we know that there could be difference in this. I've not really tested that now, but from practice we know, for instance, female are more prone to use, when we say misuse of over-the-counter drug, maybe like they say for weight, understand, to control their weight and things like that. So that might be something you see more commonly in female than male. So definitely there will be those variations in the type of substance use between male and female. Yeah.
That's good. That's interesting. I'm going to let the last question be the one that just came in, which is, what are alternatives to dealing with stress that don't involve cannabis use? And I think that's a good way to just stick it onto the brass tacks of what can we do to make our lives better. So I'll let you two both answer that question, and then we'll move on to the next session.
Sorry, that was what are alternatives to stress reduction besides cannabis use?
I believe that's the question, yeah.
I would suggest maybe going out in nature, going for a walk, meditating, yoga, music.
Yeah, I agree with Jennifer. So it's about those self-care strategies, right? And when you feel stressed, to speak out, to look for somebody you can talk to. For instance, I'm a graduate student, so I know how stressful that can be. So it's about communicating with your supervisors. And I know that there are also groups in the university that support students' mental health. These are also places that there are lots of resources for student mental health for University of Waterloo students. So we could explore all this avenue as well.
Great, I appreciate that. And with that, I'm going to hand this, I guess, back to the next moderator, which is Jerica Little, for the next session. And the next session is about data sources on mental health. Jerica, please go ahead. Thank you to our two presenters, I should say. Thank you to our two presenters for a really fascinating session. It's a weird thing to clap in this world of auditoriums, yes. but I learned a lot from this. Thanks very much.
Yes, a lot of claps for both Jennifer and Kami, who presented wonderful work. So the next panel is data sources. So this panel is a largely informational panel intended for UW members, especially students, who are interested in conducting their own research on student mental health and require access to some data. So we'll have 4 people speaking. The first will be Martin Cooke, who is a professor in the Department of Sociology and Legal Studies, as well as the School of Public Health and Health Systems. And he will be providing information on Statistics Canada information. After that, we'll have Agnes Zientarska-Kayko, who is the librarian and oversees information services and resources, and she'll be showing us how we can use the library to access a lot of different cool data sources. Third up, we have Sandra Gibson, who's the Manager of Health Education at Campus Wellness, and she'll be showing us how students can request data from the National College Health Assessment, particularly the Canadian data. And then finally, we have John Hirdes, who is a professor in the School of Public Health and Health Systems and the chair of the Mental Health Interae organization, and he'll be telling us a bit about Interae and CAIHI data. So at the end of the 4 presentations, we will have a 10-minute Q&A session where you can ask a bit more on how to access all this data. So Martin Cooke, if you're ready, take it away.
Thank you very much, Jerica. Let me just get going. So today I'll be talking about the mental health data sets that are available to study student mental health, specifically in the Canadian Research Data Centers Network. I have 3 goals then. It's good to have goals. The first is to increase awareness of the Research Data Centers Network as a resource for research on student mental health in particular. The second is to give a brief overview of some of the data that are available and to hopefully spark some ideas for use of those data sets among some of you. And then the third is to pass on just some information about where to learn more about the data and access in the Research Data Centers Network. For those who aren't aware, the research data centers are located on Canadian university campuses in addition to a federal research data center. There are about 30 at the moment. They're basically Statistics Canada offices that are located on campuses, and they offer secure access to confidential master files held by Statistics Canada, as well as to some provincial data sets. And many of the data that are held by the RDCs are also available in public use form via the Data Liberation Initiative, which Agnes might talk about through the library. But those public use files have limitations that are mainly in place to protect confidentiality and to prevent the identification of respondents. So these include restrictions on geography, removing some variables, and collapsing some other variables. The files that are in the RDCs, on the other hand, are the full master files, and these are available to researchers from universities who have an approved project and who become thereby deemed employees of Statistics Canada under the Statistics Act, which sounds like a bigger deal than it is, trust me. And then access is provided within the RDCs during regular office hours. So in Waterloo, or at Waterloo, the Southwestern Ontario Research Data Centre is in the Psychology, Sociology and Anthropology building, the PASS building. And it's open currently during COVID-19, although with some new safety measures. And the way it works basically is you do the analysis in the RDCs. Results that are taken out are vetted by Statistics Canada. Tables have to have minimum cell counts, and there are rounding rules to protect confidentiality and so on. So as I say, researchers and students at Canadian universities can have access. The approval process is short. Projects are mainly examined just for feasibility, whether the data will do what you think they'll do. And I've never seen a student project turned down. In my experience, it takes about 5 weeks or so for approval to the RDCs. So with that, I'll go over some of the surveys that are available in the RDCs. There are a lot of data sets there. Most of them are sample surveys, although the census is also available, as are some administrative data. And importantly, there are now some health administrative data available in the RDCs, including hospitalization data. But then other administrative data such like tax records are also available. So I'll give a brief overview of some of the data sets that are available for examining student mental health. Now, of course, when we're talking about secondary data, we are using what's available, and there's no perfect secondary data set. So in this case, I imagine a lot of us, what we would like, it would be something like a Canadian longitudinal student mental health cohort study or something that would have a huge sample of students. It would follow them through their university programs and beyond. Probably it would provide some periodic assessment of mental health using validated instruments, and also ask them about their living conditions, their contexts, their university experiences, and maybe we'd also have a bunch of clinical outcome data connected to these. Well, we don't have these, but what we have is generally 3 types of data available in the RDCs that might be useful. So first, there are surveys that have really some good mental health measures, but they don't focus on students, post-secondary students as a target population. They're general population surveys, but they allow us to identify a subsample of students, and we probably don't know much about their programs or their experiences of students, but we can identify students and link them to some mental health outcomes. And the second types are surveys that do focus on education and students and include large samples of post-secondary students and a lot of information about their programs, but not a lot of information about mental health. So they tend to not have great outcome measures. And then third, there are some data sources that are really about neither mental health nor students in particular, but that do have some way of identifying students and some outcomes that might be of interest. So I'll describe some of each of those. The most important probably for these purposes, if somebody wanted to start, would be the Canadian Community Health Survey. This is a large, long-running cross-sectional survey of Canadians who live outside of First Nations reserves. And although it's undergone some changes since 2001, in general, the CCHS has a set of annual questions that have then been supplemented with some theme content in various years, and then some optional content that is administered in some provinces, but not others. I'll focus on the annual component of the CCHS now, so the material that's asked every cycle. RDCs have CCHS cycles from 2000, 2001 through 2019, so that's a long-running series. It's at the moment it's cross-sectional and samples about 60,000 individuals each year, age 12 and older. And these two adjacent cycles can be combined for a sample of about 120,000. It's designed to give reliable estimates down to the health region level of geography. And students can be identified by the question, are you currently attending school, college, CEGEP, or university? And there's about 14,000 in two adjacent years that answer positively to this question. Now, some of those are going to be kids in high school, but post-secondary students, I would say, was probably about 5,000 per year, about 10,000 in each 2-year cycle. And the mental health outcomes that are available annually include several items that are of potential interest, including life satisfaction, self-perceived mental health, sense of belonging, perceived life stress, and the presence of mood or anxiety disorders. And here's an example of the use of some of these questions. Some of you, I'm sure, are familiar with this recent paper by Weens and colleagues that used, I think, from 2011 to 2018 CCHS to examine changes in the general trend of mental health amongst post-secondary students. And of course, there are other potentially important measures in this survey that might be interesting either as outcomes or predictors. So some health-related items include self-reported barriers to including one's health, intention to improve health, substance use, and other health-related behaviors. And like most other Stats Canada surveys, the CCHS includes a range of individual and household characteristics, including income, living arrangement, ethnic origin, and so on. As I mentioned, the survey is now designed so there are themes that are added each year to the annual component. And two particular thematic areas of interest, I think. One is in the 2015 and then repeated in the 2019 cycles. Those surveys included a series of questions about positive mental health consultations, and also suicidality. And then in 2016 and 2020, those cycles included questions about sources of stress, childhood experiences, and also a social provision scale, which captures social support and relatedness. So those are things in particular years that I think might be of interest to researchers looking at student mental health. And some of you will also know that the CCHS program has specific focus surveys. So these are surveys outside of the regular CCHS, and of particular interest is the 2012 CCHS on mental health. This was a specific focus survey on mental health that surveyed 27,500 people nationally, so a smaller sample. It also identified students, fewer, of course, so here we're probably talking about fewer than 2,000 post-secondary students in the sample, so fewer opportunities for complex analyses. Nonetheless, a lot of potentially useful mental health outcomes. It's getting a little bit dated now, 2012, but it includes stress, depression, generalized anxiety disorders, substance use, a number of well-validated scales related to mental health. One of the really important initiatives that StatsCan is undertaking has been, over the last decade or so, the linking of survey and census data to various sources of administrative data. And these linkages can do a couple of things for researchers. For one, it can give us better outcome measures, including clinical outcomes, than the self-reported mental health questions. And for another, it can give us a more longitudinal view on these outcomes. And a particularly important useful data linkage in this regard is the CCHS that's linked to the discharge abstract database. So some of you will be familiar. The DAD is a census of all acute care hospitalizations, in this case outside of Quebec. And the database includes ICD codes for main diagnoses related to the hospitalization, as well as information on the treatment and cost of the hospitalization. So here we have the cross-sectional survey, the cross-sectional CCHS data. Each of the cycles from 2000 to 2011 links for every person who responded to any of those surveys linked to any hospitalization that they had between 1999 and 2012. So the ICD codes on the DAD allow us to identify diagnoses that were related to mental and behavioral disorders, which is, I have to say, a relatively small proportion of hospitalizations in Canada, of course, so they're not responsible for a lot of them. But if you consider that you have in each CCHS about 60,000 individuals that are then linked to, they could have been hospitalized from 1999, before the CCHS possibly, to 2012, after they did the CCHS, you have a lot of potential observations. So I think it might be quite possible to identify students in there. So we have a lot of cycles and a long observation period. And then even more exciting, and also kind of terrifying data set to me, is now available as the CCHS annual component, as well as those focus surveys. So the mental health survey in 2012 and a previous one in 2002 that are linked now to hospitalization, so to the DAD, as well as to ambulatory care, and the Ontario Mental Health Reporting System. So others who are on the call, like I think Chris Perlman in particular, could say more about what's in OMERS, the Ontario Mental Health Reporting System. But in general, those data provide an opportunity to examine more clinical mental health measures for students. Now, of course, those are only Ontario data, and it further restricts the size of the sample, but it's potentially very powerful for those powerful information for those who are in that sample. So those are I would say the main sources of mental health related data that are in the RDCs right now that I think might be useful for looking at student mental health.
Hi, Martin. Sorry, we just need to go to the next presentation now.
Okay, great. Thanks very much. If you have any questions about how to access those, the first place is probably the CRDCN, and then you can contact me directly. So thanks very much.
Hi, everyone. My name is Agnes Zientarska-Kayko, and I am going to talk about the resources available through University of Waterloo Library. And this is just going to be a quick overview of the data available through the library, because there is a lot information to include, and I only have a few minutes to do that. So finding relevant health statistics and data can be challenging, and we already heard from Marty that there are RDCs, and you can find a lot of data on RDCs. However, you not always may have time or be able to get to that data, and all you need might be is just the data available either publicly through the Stats Canada page, website, or through University of Waterloo library. So first, I want to show you the screenshot of Statistics and Research Data Guide. This is your starting point for all data searches in the library. This guide not only provides information and includes links to statistics and data sources, but we also have various help guides on how to download data from the library, and as well as our contact information, where you can reach both of us, Sandra and myself, Sandra Kies, who is a data librarian at the University of Waterloo Library, and myself. And we both monitor this email, so when the questions are coming, we are able to respond on a timely manner. Before I talk about the way of accessing data, let's mention something about DLI. Marty already mentioned DLI. Some of you might not be familiar. What is DLI? DLI is stands for Data Liberation Initiative, and University of Waterloo Library is a member of DLI, and it is a partnership between post-secondary institutions and Statistics Canada. The idea is to improve access to Canadian data resources. DLI makes specific data sets available to its members, which includes public use microdata files, as well as some special data sets which are not made publicly available on their website, but only through DLI. Now, how do you get to those DLI files? So Odyssey. If you've never heard of Odyssey, this is a web-based data exploration tool which gathers data from a number of sources. The main source being Statistics Canada. I listed here on this slide some of the collections the data is coming to, you can search those collections through Odyssey. Links to Odyssey can be found on our research guide. As I mentioned, it's your starting point whenever you're looking for something data related. Worth pointing out that not only Canadian data is available through Odyssey, but also we have access to ICPSR, and University of Waterloo is a member of ICPSR. So if you're looking for some US data or international data, don't hesitate to search Odyssey for that as well. There are two ways of searching, finding data on Odyssey. One of them is direct browse, which allows you to browse data repository, which is also known as a Nestar. It's a software which we use to extract the data, but also through Nestar, you can do some manipulation and extracts the entire data set as well as only parts of it. Every time you are browsing and looking at the data sets, all the documentation will be included, so don't forget that. The other way of getting data from Odyssey is by searching, and you can search by variables, by survey names, series, and keywords, and that allows you to download data sets in various formats. So again, whatever software you will be using, you can download that data set in that software. If you have any questions at any point when you are looking for data sets, not finding what would you like to see, don't hesitate to reach out to us. We we have contact with DLI, who are people working at the DLI. They provide assistance to us if there is something we don't have access immediately. They will advise whether maybe custom tabulations can be created. That comes with the cost, but you are not asked to pay unless you agree for that custom tabulation to be created. And my last slide is to show you some of the data which are health and mental health related data sets available in Odyssey. So something new in this pandemic era is COVID-19 related data sets. And as you can see, there are 3 different ones. Canadian Perspective Survey Series, which includes impacts of COVID and monitoring on the effects of COVID, as well as impacts of COVID on post-secondary students. So those researchers who are doing very timely research on pandemic right now and the effects on Canadian society may want to look at those data sets. Other data sets, public use microdata files available through Odyssey are Canadian Community Health Survey, which Marty already mentioned. There are some data sets talking about tobacco and nicotine survey. So these are all data sets you can access through Odyssey. I think my time is up. If you have any questions, please don't hesitate to reach out to us.
Hello, my name is Sandra Gibson. I am in campus wellness and work in health promotion. I'm going to share some information on the National College Health Assessment survey that has been done on our campus for 3 years in 2013, 2016, and 2019. And how you can access the data set for the Canadian research or the Canadian cohort that we use as a reference group. So I'm going to share my screen, and I've also provided these links to Grace and Andrew, who have been great at helping set up the conference. So they can post the links in the chat, and then people can go there to get them if they want to later on. So I'm just going to try to share my screen. I don't see the share button. Oh, there it is. Okay. Okay, so first of all, the National College Health Assessment data is available on the University of Waterloo website through IAP. And if you were to scroll down, you could see that we have posted the survey instrument and the results, the executive summary for University of Waterloo and the Canadian reference group for the 3 years that we did the survey on our campus. For the 2019 survey, if you're not familiar with the National College Health Assessment survey, it is for post-secondary students. So where Martin had said some of the research that he was talking about, you could stratify by university student if they answered that question. But here, this survey is for post-secondary students, and it's looking at health behaviors, attitudes, and perceptions. And we use this data in campus wellness to look at our services and our procedures and our programming to help improve it for University of Waterloo students. So that is the survey. If for the 2019 version, I'm going to pull it up here for a moment. You can see that there's lots of mental health data available. So I just pulled it right down to the mental health questions. So looking at hopelessness, overwhelming, feeling overwhelmed, exhausted, lonely, sad, depressed, anxiety, angry, self-harm, considered suicide, attempted suicide, various diagnosis or treatments for some mental health concerns, and also some questions about whether they were accessing treatment on or off campus sometimes. So a very rich data set for I would say master's level students that might want to do secondary data analysis, or for researchers, or for campus people that are interested in this area. When we did the survey in 2019, University of Waterloo population students that responded, we had just almost 2,800 responses. The Canadian reference group, which is the data set that you would use to do research, comprised of 58 Canadian post-secondary institutions with responses from over 55,000 students. So that's the data set that you would use. To access that data, you would go to the American College Health Association. They run the data here in Canada, and then you would you're able to look at it and apply to get the research. I'm sorry, here we go. So we've got our National College Health Assessment, and then this tells you a little bit more about it. And then if you want to go to research projects and data access, you would start there by sending an email, and they will send you a Word document where you would complete the data access form, and for the variables you want for your research question. And once that's approved, usually 4 to 6 weeks, they will send you the data set to work with. I wanted to let you know that coming up, so in addition to having this data set for the National College Health Assessment Survey, we will be doing another survey through Campus Wellness either in fall 2021 or winter 2022. And another option we're looking at is this new Canadian Campus Wellbeing Survey. So once again, I did post all the links in, or I provided the links that can be posted in the chat. And similar to the National College Health Assessment Survey, looking at a lot of mental health questions, looking at mental health assets, mental health deficits, suicide and harm, and health-seeking behaviors, in addition to general health and many factors that may affect mental health, as one of the first presentations referred to substances and behaviors such as sleep, physical activity, and support. I think that's what I had. Again, I did post all the links, and I'm willing to answer any questions as well. Well, I want to share, actually, I will share that with the 2016 data, we did stratify it by graduate and undergraduate students, and we presented that to the Graduate Studies Office. And this year for 2019, we shared the data by faculty, so we had it stratified by faculty, and we have presented to AHS, math, and engineering. So we're hoping that we can make connections with the other faculties that might want a little bit of the data by faculty. Thank you for having me.
All right, so Jerica, can you confirm if my slides are showing on the screen?
They are showing, yes.
Okay, thank you, everybody. So I'm John Hirdes, professor at the School of Public Health and Health Systems. I'm going to talk about some healthcare data sources that you could access at the University of Waterloo for doing research on student mental health related questions. And I guess the thing to emphasize is that you can use different data sources to answer or address different types of research questions. So if you're really interested in how common mental health concerns are in the general population, that's where you need to use survey data sources from StatsCan, Health Canada, some provincial ministries of health sometimes do these surveys. And these are especially helpful for looking at mental health issues that have relatively high prevalence in the general population. So depression, anxiety, substance use disorders, you're going to have pretty good success at getting prevalence data for the general population with the types of surveys, particularly that Marty mentioned, or the campus surveys that Sandra mentioned, will be very good sources for that. It's a little bit more challenging, though, to get at some subpopulations with severe mental illness, and that's where data from healthcare settings might be useful to take a look at. So if you think about people with severe psychosis, with severe suicide-related behavior, persons with personality disorders, the prevalence of those in the general population is going to be relatively lower than you will see in clinical settings. So getting data from healthcare settings may be helpful in that context. And also, if you're interested in people who have very high levels of mental health service use, you'll probably need to use healthcare data to get at that population with sufficient sample size for your study. So where can you get this information? Well, a starting point is the Canadian Institute for Health Information, or CIHI. they have a variety of different types of data that you can access. So they have aggregated summary reports that you can draw from if all you want is background information on how common is an issue in the general population. They've got many online interactive tools like the yourhealthsystem.ca website. They have an online cost estimator, and you can also make record level requests. And you want to watch out for releases that come from CIHI, particularly as part of the Canadian Shared Health Priorities Initiative, which is a federal, provincial, territorial initiative for reporting on the performance of the health system. So this was just a recent release by CIHI on suicide-related behavior and intentional self-harm in Canadians, where they show that about a third of those people hospitalized for self-harm are young women, and of the people who die by suicide, about 30% are middle-aged men. So if you want quick contextual information about major mental health concerns like self-harm behavior, CIHI is a ready information source for much of this type of data. You can also, though, request data from CIHI that you can analyze directly. So you can ask them to do aggregated tabulations of data, where they'll give you a summary report with basic descriptive information or calculations of indicators. Or you can ask for record level data where you get de-identified person level hospital records that you can analyze as part of secondary data analysis. If you're a faculty member, you have to pay for that. If you're a grad student, though, you can get that at no cost. The main thing to know is that it will take time. The typical turnaround time will be in the range of 4 to 6 months. So if you're a master's or PhD student, you would need to do this early in your career. If you're an undergrad thesis student, it may be a bit of a challenge to get the data in that time period. And anyways, I've given you the link here that you can go to request those data. A different type of healthcare data that is available on campus through my research group are inter-eye data holdings that a few folks have mentioned. And the Ontario Mental Health Reporting System that Marty mentioned is actually part of this data holding. And so this just gives a quick graphic of the implementation of these assessment tools across the health system. A simple point is that we now have data on over 16 million assessments on over 4 million unique Canadians across the country, and that includes 1.5 million inpatient psychiatry assessments that are part of that Ontario Mental Health Reporting System, which is which holds data from Ontario, but also Manitoba and Newfoundland. So as an example of work that we've done with these data, we did a study for the Committee on Student Mental Health to try to understand patterns of mental health service use among university students. We used about 11 years of data to look at people with university degrees or participation in the 18 to 24 range. And we could identify people in different regions linked to different universities. So we had about 12,000 individuals that were admitted to inpatient psychiatry with those characteristics. And we were interested in two things. One, why are university students admitted to inpatient psychiatry settings in these different regions? You can see across all areas, typically the most common reason for admission to inpatient psychiatry is harm to self. In the Waterloo region, about 65% of people admitted to hospital in our region that are university students are admitted for self-harm.
Sorry, John, we have to start our Q&A session.
Okay, I one more slide and then I'll be
all
done.
Right.
And you can see risk of harm to others is less common, whereas self-care issues are also more common. So you can use this for quite granular information at the individual level. But we also have clinical scales. So this is a measure of severity of suicide risk. And you can see about a third of the people in the Waterloo region that were admitted to hospital have very high risk of suicide-related behavior, which is actually fairly comparable to 5 other regions. So if you'd like more information about those data, feel free to contact me or Chris Perlman directly. Otherwise, contact CIHI for the access to the CIHI data holdings. Thank you.
Great. Thank you, everyone. That was a presentation I know I would have loved to have seen when I was an undergrad and did not know that we could access a lot of these sources freely as students. One question that I have broadly for everybody is if you want to use this data and publish it as part of an academic article or in a news site, are there any additional steps you need to go through?
For the CIHI data and the INTRI data, you would need to do ethics clearance. We do have ethics clearance capabilities already done for the INTRI data that we hold, but you would need to do ethics clearance and go through the CIHI review process for those data.
For data coming from the library, the only thing you would need to do is cite it. Yeah.
Yeah, for the RDC data, you do anything that comes out of the RDC does have to be vetted for confidentiality by StatsCan, and then they just ask that you include a note to say that you use the RDC network.
You would use, similar to what John was just saying, you do ethics clearance and you'd be requesting the data, and then it can be published.
Okay, and are these steps applicable for students who are using it for their thesis, or are they slightly more lenient rules in that case?
Not for the CIHI data holdings. Would be the same rule for students or faculty. So irrespective of whether you're publishing it or not, you would need to do the same ethics clearance for accessing those data. But that doesn't mean it's very onerous. It's definitely a manageable and timely process.
Same for National College Health Assessment data access. The process is the same for anybody who wants to use the data. If you were to do a journal article search and put in National College Health Assessment, you will see 20 years of the research from the US and more within the last 9 years, more of the Canadian research. BC, University of Toronto, several other institutions have really started working with this data quite extensively.
For the RDC data, student applicants to use the data need to include a letter from their supervisor, basically attesting that the student has the capacity to do the analysis and that the supervisor will also support them in that. That's the only difference.
And then for the library, it's
yeah, for the library, it's as long as it's the data is available through DLI and Odyssey, you just download it. If you need any help, you contact us. If you don't, you can do it yourself and just cite it. That's all. The problem starts if there is if you think that their data may be available there, but you cannot find it. Again, contact us, and custom tabulation is available. But that's a different story.
Okay, perfect. Well, we did have one question from Rona for John about the distribution of Waterloo compared to other regions. There will be a presentation on INTRI data in this area later on by Chris Perlman, so we'll hold on to that question. In the meantime, I just want to thank all of you again for providing us with this information on how to access all these different data sources. I will remind the audience that if you have further questions about how to access this data, this is something that you want to use yourself, you are free to contact all of these individual people at any time. They can be found on the Waterloo website as well as in the package we disseminate later. And for now, we're going to move on to a 10-minute guided stretch break to help our bodies feel a little bit better from sitting all morning. And this will be run by Stacy Majuri from the Athletics and Recreation Department. So feel free to guide us through some stretches, Stacy.
All right, hi everybody. Am I good to go here?
You are.
Awesome, okay. So I just want to chat quick. It's just a little quick wellness break. So if you do need, obviously, to get up and walk around, that's good. A reminder for your wellness break is to always have some water with you today and every day while we're sitting at our computers. We're going to do a quick little stretch here. I am going to get you to stand up and kind of maybe shake out some energy from sitting all day or all morning so far. And then we're going to do a little, I'm going to teach you how to do a box breath, which is a little bit of deep breathing because our mental health is equally as important in our wellness breaks as our physical health. So if everybody can stand themselves up, I'm just going to get you to kind of shake out a little bit, give yourself, you know, get out some of that energy, get moving, get the blood flowing a little bit. Okay, and then we're going to take our hand and you're just going to reach all the way up to the ceiling. You're going to reach up onto your tippy toes and try and touch up into your ceiling, and then you're going to let your hands go really quick and just swing them out. So again, getting some more blood flow in there. It'll be a little bit easier to stretch than if we are you know, cold from sitting all day. So again, all the way up to the ceiling, up onto your toes, try and touch that ceiling, and another release down. We're going to do that one more time. So all the way up, touch up to the ceiling, up to your tippy toes, stretch, feel like someone's pulling you from one end to the other, and then we're going to let that go again. Awesome. Now you're going to take your hands, you're going to interlock your fingers like this, but we're going to do it behind our back. So you're going to come around your back. I'll turn this way for you, and we're just going to try and round those shoulders out a little bit. I've been slumped forward all morning. So we're going to round our shoulders out a little bit here, get out of our desk posture. If you want to move around a little bit, you can. Keep that blood flowing a little bit better. Good, and now what I'm going to get you to do is release those arms a little. Now you're going to take your chin, and I want you to, this is probably going to be the best view, but you're going to take your chin, and you're going to do a double chin. So if you think about your chair posture, our heads are always forward, trying to look at our screen, and we want to remind our muscles back here that they have a job to do. So we're going to extend the back, make a double chin, hold that for 2 or 3 seconds, and then relax, roll out your shoulders a little bit. And again, push back, double chin. Good, and extend back out, roll your shoulders a bit. And you're going to do that one more time. So you're going to push back, double chin. Good, and release that. Okay, give it another shake here. So now what we're going to do is try and stretch out our traps, because these areas, this upper back, upper shoulder area gets really tight. So we're going to take one hand, you're going to put it behind your back. You're going to take your other hand, you're going to put it just on the side of your head here. You're going to stand up nice and tall, so head's reaching all the way up to the ceiling. And you're just going to take this ear and you're going to put it down towards this shoulder. So don't yank too hard on that head, just nice and gentle. And what I want you to try and do here is try and push against your hand for a couple of seconds and then release and see if you can stretch a little bit further, and do that 2 or 3 times. So I put a little bit of pressure on my head and I try and push up, very, very gentle. And then I relax and I try and pull my ear a little bit further. We're going to hold that. Again, we're going to push up again and then relax and try and pull a little bit further. Now from this position, I want you to take your chin and I want you to turn it towards your armpit. So my hand here goes more towards the back of my head, and I'm going to feel this more towards the back of my neck. So if that area is really tight for you, then you might really feel on that. I like to take my hand right back here and kind of pull my head up and out a little bit. Good, and shake that out. So we'll go ahead on the other side here. So first arm behind your back, other arm on the side of your head. Now ear goes right down to our shoulder. Again, nice and gentle, don't yank on this too hard. There's some pretty sensitive areas in here. So now you're going to take that pressure of your hand and you're going to push against your head and try and lift your head up. Hold for a couple of seconds. Then we're going to relax that and try and stretch just a touch further. Good, push up again. And then relax that hand and that pressure and try and pull just a little bit further. Now you're going to take that chin, turn it towards your armpit, and that head goes towards the back of your hand goes towards the back of your head. You're trying to get back in here, sort of the back of your neck area. Good, and give that a little shake out. Okay, so I'm going to move my screen a little bit here. I'll see how much of my legs you can see here, but we're going to try and work out our hips a little bit. So if you need to hold on to something like your chair or your desk, go ahead and do so. We're going to balance on one foot. So your knee's going to come up into the air like so, And you're just going to try and pull that right up as high as you can. And from this position, once you get a good height, again, use something beside you to hold on for balance if you need to. I want you to push the floor away and try and extend your head all the way up to the ceiling. So again, it feels like someone's pushing you pulling you from one end to another, pulling you right apart. And then you're going to take that same leg, you're going to come back, you're going to hold on to the top of your foot, and your heel's just going to come up to your back end here. And from this position, what I want you to try and do, if you're not feeling much of a stretch, is take your pelvis and tilt it under. So kind of tuck your bum under, and then you'll feel that stretch a little bit more. So tuck your butt under or push your hips forward, and you should feel even more stretch in that front of your leg. Good, we'll give that a little shake out. So you're going to go on to the other side. So again, hold on to something if you need to. Foot comes all the way up. Once you feel good and stable, I want you to press away from the floor with that bottom foot. Tighten that glute up, and then head reaches all the way up to the ceiling. Good, now you're going to take that same leg, grab onto the top of your foot here, and you're going to get a quad stretch and the front of our hips. So again, pressing your hips forward or tucking your bum underneath will help to intensify that stretch if you need to do so. Good, so we're going to let that go. What do we got here? Okay, I'm going to get everyone just to sit down in their chair in a comfortable position. We are going to do a couple of box breaths here. So I'm going to suggest that you work on your own time. So I'm going to go with a 5-second box breath. And what that means is we're going to hold it for 5 seconds. Sorry, we're going to inhale for 5 seconds, hold 5, exhale 5, hold 5, and we're going to repeat that. Probably we'll do 5 times. You want to do, at least 3 to 5 times to get a good effect for it. But if you feel you have your lung capacity isn't allowing you to hold for that long, then that's 3 seconds or 4 seconds. And if you feel your lung capacity is really wonderful and you can hold for longer, then you go ahead and hold for longer as well. So this is just something that you can do in the middle of your work day or work break, and it just takes you a second to relax yourself. So here we go. You ready? So we're going to inhale 1, and that's 5. You're going to hold. You're going to exhale through your mouth and hold and inhale. Hold. Exhale through your mouth. At the bottom of that exhale, really try and bring the shoulders all the way down. And hold. We'll go 2 more times. Inhale. And hold. And exhale. Again, on that exhale, blow everything out and try and let that whole body relax. And hold. We'll go 1 more quick one here. Inhale. And hold. And exhale through that mouth. Big exhale. Blow everything out of those lungs that you have. And hold. And that's it, you are done. So hopefully you feel a little bit more relaxed, maybe a little bit more energy for your day, and have a wonderful rest of your conference.
Great, thank you so much, Stacey, for that.
Yeah.
Sure, it helped all of us during our break. So thank you very much for doing that. We're now going to move on to our next session on suicide prevention. And our presenters today will be Dr. Chris Perlman, who's an associate professor in the School of Public Health and Health Systems Chris has done a great deal of work in the area of suicide prevention, including publishing a report for the Ontario Hospital Association. And the second person is Sherry Billets, who is a social worker by training, but she is our new Director of Counseling Services for the University of Waterloo. And Sherry will talk about work that's done on campus around the area of suicide prevention. And I've been very gratified as chair of the Committee on Student Mental Health to have both Chris and Sherry as very active participants in that committee from its inception. So with that, Chris, I'll turn it over to you to get us started.
Okay, thank you very much for that introduction and for all the great talks so far. So I'm just going to share my screen here. So today I'm going to present about understanding suicide risk for monitoring and preventing suicide. This is you know, I don't have to tell anyone about how serious of a topic this is and the importance of understanding suicide risk and prevention strategies, not only in post-secondary contexts, but I think for all aspects of our everyday lives. So these statistics are from the National College Health Assessment 2019 data set. So it's about 55,000 students across Canada who were surveyed. And if we look at the bottom row, the first slide tells us about suicide ideation. So students that have considered wanting to die by suicide in the previous 12 months. And it's about 14% of the males and about 17% of females. The attempts to die by suicide, it's about 2% among males and almost 3% among females in the prior 12 months. And these statistics are rather alarming. If we look at the Canadian Community Health Survey data for 15 to 24-year-olds, for instance, the rates of suicide ideation are about 6% for individuals in that age group, and about 1% had attempted to die by suicide. So the rates we see here are somewhat higher than what we see in population-based survey data. If we look at internationally at research that's been done internationally, this was a study done on over 8 million students in Japan between 1989 and 2012. And what they found was among the whole sample, the rate of death by suicide was about 15 per 100,000 across all of the students that they had data for. When they looked at trends over time, they compared the trends of deaths by suicide to other forms of mortality, such as accidents and medical conditions. And while rates of death of other forms of mortality were decreasing over that period of time, rates of death by suicide increased and basically doubled from 1989 to 2012. So that tells us that, you know, it's a constant and increasing problem among this population for sure. When you look at, they also looked at deaths among individuals in different disciplines, and there was a big difference between the rate of death for males versus females in humanities and sciences, for instance, where the rate of death in humanities was almost 20 per 100,000 for males and about 8% for females. However, when we looked at medical sciences or dentistry, the rates of death by suicide were similar for both sexes. So it also brings into play an important point around looking at discipline specific rates in addition to student bodies overall. And I think the point here is to think about perhaps the determinants of and risk factors for suicide among different subpopulations of students as an important area of further research, but also in terms of prevention strategies. Now, if we look at some work that Jerica Little has actually done as part of her PhD analyses under the supervision of John Hirdes and Walter Mittelstadt and myself, she was able to look at severity of self-harm, so risk of suicide, amongst several clinical populations for 18 to 24-year-olds, 25 to 34-year-olds, and she actually looked above 35-year-olds as well. Here in this graph, what we see are three different subpopulations: an inpatient psychiatry population, a community mental health population, so something similar to the Canadian Mental Health Association and the services they would provide, and emergency department data. These are all based on different inter-eye assessments that John had described previously in another presentation. What we see for the 18 to 24-year-olds are very high rates of high risk of self-harm and suicide among those admitted to inpatient psychiatry. Upwards of 50% of all of those who are 18 to 24 who are admitted to inpatient psychiatry have are at a high risk of suicide. We see in emergency departments and community mental health agencies, moderate to severe risk tends to be more common. But again, here we see 20% of all those in community mental health are also at high risk, and about 25% of those showing up in the emergency department who are 18 to 24 at high risk as well. So it shows us that 18 to 24-year-olds have the highest prevalence of suicide risk across all age groups, and the severity, the proportions at higher risk decreases as age actually increases. So as John alluded to previously, we had done some work with the Ontario Hospital Association to develop a resource guide on suicide risk assessment that not only reviewed risk assessment tools, but also the principles and processes for risk assessment. An important distinction in these processes is identifying and understanding what are risk factors and warning signs for suicide. So risk factors being factors that sort of predispose someone to risk. They have a longer term potential for that predisposition. Warning signs implies a more imminent risk that may be more episodic and variable over time. So prior research by Rudd et al. Has really teased out what are what they call potentiating risk factors and warning signs. And these are often used for the basis of screening for suicide risk. But again, it's important to understand these factors so that in all of our lives, when talking with others, we understand what might be potential warning signs and as well as underlying risk factors that a person may be experiencing. So the risk factors being things like, loss of close relationships, social isolation, potential prior trauma and abuse, as well as deaths by suicide that may have occurred amongst family members or other members that are close to the person. Warning signs are things that are involve things like changes in mood, withdrawing from family and social relationships, giving away possessions, increasing changes in terms of reckless or impulsive behavior, as well as expressions of hopelessness about the future. And then at the pinnacle being, expressing ideation, expressing that a person may have a plan to die, seeking out means, seeking different means or ways of potentially attempting to die by suicide, as well as threatening to die by suicide. And the upwards arrow tells us a little bit about, where people would fall in terms of their levels of risk. And the presence of any kind of warning signs indicates a high level of risk, and certainly a person should be supported in seeking mental health professional mental health supports. At the highest risk level, we certainly would want to engage in immediate help for that individual. Another important point to consider for students is and any populations as well, is the idea of predicaments. And this is where someone may feel that their back is simply to the wall, that something awful has happened in their own perception of an event, that it's awful and they perceive no way out. So those could be unacceptable life circumstances to that person. So we could think of extreme financial loss. We could think of extreme loss in terms of educational opportunities as well. feelings of guilt or shame or humiliation around that sort of loss. So it's important to understand and recognize those kind of predicaments when thinking about understanding a person's level of risk. It's also important to understand protective factors. So these are factors that may identify hope or things that one could build off of to help balance out the really negative feelings that they may be having from risk factors and warning signs. And so they can be used as an actual means of encouraging hope. So other research has looked at risk and protective factors among students. So this was a systematic review done of 27 studies. And what they found was the strongest risk factor across all studies was certainly depression. So there's a very strong relationship between underlying mental illness and risk of suicide, and depression being one of the main drivers of that relationship. Other risk factors included perceived burdensome, feelings of loneliness, thwarted belongingness, so attempts to try and belong and engage in a community, and in that person's perception, it's been thwarted. Issues such as sexual assault and other kinds of traumas, sleep issues, and hopelessness. Of course, protective factors being, having reasons for living, having a sense of hope. So again, those can be leveraged. Even things like what can get you to the next day, what can get you to tonight, to leverage to help the person get to the support that they may need. Other studies looking at protective factors among students also noted an important relationship between family supports and how family supports moderate the association between feelings of loneliness and suicide. So in other words, if a person's experiencing a sense of loneliness, but they do have a good connection with family supports, that they're less likely to be at risk for suicide. So it's important also, as students emerge into adulthood and venture away from home, that we find ways to continue to support them so that they feel that sense of belongingness. So I wanted to also mention about suicide risk assessment, because that's something that often comes up. What tool can we use to identify people at risk to get them the help they need? And there's been some debate in the psychiatric community about this. So Large et al. From Australia mentioned that, in inpatient settings, using risk screening and scores could actually be detrimental in preventing suicide. So focusing too much on predictive validity of the scores of these kinds of tools. Other psychiatrists have sort of said, well, it's a little risky, to dismiss this idea of risk assessment. So how do we go about doing it? Well, poor risk assessment and poor communication about risks are actually root causes of death by suicide in hospitals. So we know it's an important patient safety, and it's an important safety factor, I think, in any healthcare context. It's about finding the best practices on how to do it well. And so when choosing risk and screening tools, it's important to consider a few things. One is in terms of public and population health screening, it's not always helpful to look specifically at scores of risk assessment tools. So use a tool and think about cutoff scores for who gets into a service and who doesn't, because it's really difficult to establish good sensitivity and specificity of those scores, because suicide is a difficult thing to be able to predict scientifically. Now, in clinical context, that might be different. There are tools such as the severity of self-harm tool embedded in the IntraRide tools that actually performs quite well in hospital settings in predicting risk. But more importantly, with screening, at a public health level, it's important more so to focus on tools that help you sort of assess the cumulative risks and warning signs that a person may be experiencing, to understand the complexity of what's going on. It's also useful for information gathering and corroboration. So it's important in this context, not, if someone comes in to a certain care setting for screening, that we don't just hand them some paper survey and say, hey, fill this out. Of course, we want to listen, that occurs, but then we want to do something with that information and respond to the information that they've presented to us. So that information can be helpful in corroborating level of support someone may need. And I think, just to summarize, for all of these processes, the most important thing here is that risk assessment is not you know, researchers want to do risk assessment to try and best predict suicide and so forth. But when we do this from a public health and safety standpoint, it's not about predicting suicide accurately. It's about understanding the basis for one's feelings, emotions, and thoughts of wanting to die. And really listening and trying to allow for a more informed intervention. So it's about asking with compassion and empathy, taking an interest in the person and actively listening to what they're telling us, and then providing that empathy and support and referring the person to the most appropriate care setting possible. So thanks very much, and I look forward to any questions that anyone has.
Great, thank you for that great presentation, Chris. Very helpful information. We are starting to get some questions in the Q&A. I'll save those for the question and answer session after the presentation by Sherry Billets. So Sherry, we'll turn it over to you, and then after that we'll have questions for both of you.
Sure. Good morning, everyone. Thanks for having me to talk about this very important topic of suicide prevention on campus. So I'll just share my screen. So Chris Perlman already went over a lot of this information, which was great to have the overview, and definitely more fulsome than what I'm presenting today. But the one that really is highlighted here from the National College Health Assessment is that 2.4% had attempted suicide in the last year. So this was based on answering the question, in the last 12 months, have you experienced the following? So Chris also discussed protective factors, and one of those that I really wanted to highlight, in addition to some of them that he had shared, is the feeling of connectedness to individuals, families, communities, and social institutions. So that's one that I wanted to highlight through the presentation of what's happening on campus. So I wanted to link it to our values as a university, especially highlighting the one, we all belong. And to the strategic initiatives of the university, so that Waterloo will make an impact on its campuses and around the world by fostering inclusivity, a sense of belonging, and a culture of involvement, as that's one of the protective factors when we talk about death by suicide. So some of the prevention strategies that are happening across campus, I wanted just to also bring it back to the President's Advisory Committee on Student Mental Health and some of the themes. So some of the recommendations that we're working on the Committee on Student Mental Health. So that's really looking at some systemic factors, such as policies and practices, making sure that we're creating an inclusive and supportive campus culture, that we're increasing mental health and awareness and communication across campus, prevention and early intervention, and also service access and delivery. So one of the ones that I wanted to highlight as well is the work of the Wellness Collaborative. So that the goal of the Wellness Collaborative is to keep people well by creating supportive environments and a culture of wellness. So how this ties into a protective factor is that across campus, if there's more awareness on suicide prevention and also on mental health and response, how that is a protective factor across campus. So the collaborative has identified 5 priority areas, and that is, again, bring it back to the systemic factors, so that there's an institutional commitment to wellness at all levels across campus, an emphasis on mental wellness, spiritual wellness, sense of belonging, and a supportive environment for active living and healthy eating. Also, as part of the Wellness Collaborative, there's a lot of work happening across campus in terms of developing a mental health literacy certificate program. So that will be increasing the mental health literacy for all faculty and staff across campus, and tailored to roles. So understanding that some roles need different levels of training, and tailoring that for those roles. So there are current trainings that are available, and you can find those through the Campus Wellness website. So there's QPR, Question, Persuade, Refer, More Feet on the Ground, Mental Health First Aid, Safe Talk, and Assist. So those are some current trainings that are available. And I wanted to talk about also some interventions as well. So part of in working in counseling services, we often receive emails from concerned people across campus. So it could be an advisor, it could be a professor, it could be a parent, a loved one, expressing concern about a student. So they might reach out and say, I haven't heard from this student in some time. Can you please reach out to them and offer them some support? So that's something that counseling services does regularly. We could get several of those emails a week. When we do reach out, most students do connect back with us, and we're able to triage for the level of urgency to see if there is some risk there. We do have crisis and mental health appointments, so students may either come into counseling services or they may go to health services for mental health appointments, and you'd be meeting with a counselor. So those are available on a daily basis for students who are in distress. And part of that would be engaging in safety planning with the student. There's also group supports available through Campus Wellness as well. One of those is Skills for Safer Living, which is a suicide ideation group for students who have been experiencing suicide ideation for some time. So it gives them that group support as well. So I wanted to just share some urgent and emergency contact information, which I believe was done at the beginning of this day as well. And also just to share the counseling services information there, so that if you know of somebody who you're concerned about or you're needing to reach out yourself, that you have the extension to phone into counseling services and get the support you need. Thanks, John.
Thank you very much, Sherry and Chris. So I've got some questions that have appeared in the Q&A session already, but I'll start with a couple of questions from myself, perhaps to get the conversation going as well. And I want to think in terms of somewhat practical terms of situations that we may find ourselves in. And I think, you know, we've heard the answer before, but I think it'd be helpful to hear it directly from both of you. If you know somebody where you think that they have ideas of harming themselves, is it okay to broach the topic with them, to ask them about it and to talk with them, or does that increase risk of them actually carrying something out?
Chris, did you want to answer first?
I'll let the clinician.
Okay. Yeah, sure. Yeah. I would say, and I know there is some thought about does that increase risk? I would say that asking someone directly is completely okay, and it also takes away some of that stigma associated with it. In counseling, we would often just ask students, are you thinking of harming yourself? Have you had thoughts of harming yourself? Are you wanting to die? Just asking directly.
Right. Chris,
yeah, and that certainly echoes, you know, the best practice, of course, literature and standards of practice. I know, you know, anecdotally in my own duties and talking with students that are having difficult times, there's been instances where I've sort of felt that this might be an issue, and I asked them directly, and I was amazed at how open they were about talking about it, because, you know, I think in these circumstances, people want help, right? They don't necessarily want to die. They just don't see any way out, right? And so being very open and upfront about asking, and then ensuring that you're committed to listening as the next step.
So then let's assume the answer is a yes, and that you're a person who doesn't have a lot of clinical expertise or background in mental health. What do you do next? What's the next step after you broach the topic with somebody and they've said yes? Sherry, maybe we'll start with you.
Sure. I think that would be when you would be asking if they have supports, if they are accessing counseling. At that point, they may go into more of a history or a story. Obviously, if you ask that question, they probably won't just say yes and leave it at that. But making sure that they're connecting to some supports, and if they seem unwilling, you can always reach out to counseling services as well, and say, I had this conversation, I am concerned about this student, can you reach out to this student? And then we would take it from there.
And Chris, any further thoughts?
No. I mean, that's in my anecdotal experience, that's been the case, and certainly in best practice that I've read too. I think the key thing with this is we have to think about the levity of this kind of circumstance, and we're all busy. We have lots going on, and we might have another meeting to get to or whatever. That doesn't matter. You know, it's someone's life and well-being, right? And so I think it's important to take the time to listen, but then to know the next steps. And we're so fortunate at Waterloo to have an amazing counseling service and health service that is very open to these kinds of calls that Sherry mentioned, as well as a vast amount of training that's available to help understand these circumstances more, because it is a little bit about, I think, exposure and practice. Right? It's easy to talk about this, but to think about what would I actually do in that situation, and that's where the training is really important.
And I think one of the things that's helpful for everybody on the campus community is to at least get some information for ourselves about what the resources are. So we all know that if we see a horrible accident happen on the street and in downtown Waterloo, we know how to call 911 as a basic citizenship effort. I think we could all try to get information about where we could refer to folks, and that information is widely available from campus wellness, and there's also lots of really great training programs through campus on talking about suicide, as well as through CMHA. So there are things we can do each as members of our community to help those around us who may have these concerns. I'm going to flip the question now a little bit for both of you and put it in personal terms. So there was a remarkable study that I saw out of New Zealand several years ago that looked at lifetime exposure with mental health concerns. And it basically made the argument that if we look at the course of our entire lives, only about 10% of us will live a life completely free of mental health concerns. That we'll never have a moment in our lives where we have concerns with our mental health, which means that there's going to be variations in day-to-day in our own experiencing. So what's the point where an individual should say, well, look, this is bothering me enough, I should probably talk to somebody about it. So if now you're the person who's having the thoughts about your life isn't good, it's not worth living, what's a fleeting thought versus a persistent concern? I think that was mentioned, Sherry, in one of your slides, where, you know, if you're having these feelings, you really should talk to somebody.
Mm-hmm. Yeah, so the question, when should you reach out? Yeah, I think if you're having that thought, should I reach out, that's a good point to reach out. I know some students have come in, and during their intake session they might say, I don't know if this is severe enough to warrant counseling. I've had people ask that before too, or almost minimizing their own concerns and thinking maybe I'm using a spot that another student might need. I would say if you're feeling like you've been struggling ongoing for more than a few weeks, if you're noticing changes in your behavior and your usual patterns in life, that I would say that would be a time to reach out. I wouldn't think that there's a reason too small to reach out. I think if you're wondering if you need help, it's probably a good time just to reach out and talk with someone.
Chris, any other thoughts to add to that?
Yeah, I think I certainly would echo what Jerry said, and I think there are so many tools and resources available to us now to increase our mental health literacy overall. Because it's easy to sort of say, yeah, I'll tough it out. You know, I've heard the term white knuckle it, right? I'll just squeeze the steering wheel and I'll get through it. And that doesn't probably make things better, right? And so there's different kinds of tools, even in, you know, for the general population. If we go to wellnesstogether.ca now, it's a free tool for all Canadians. I've gone on it myself. There's a series of checklists that you can go through to check on, you know, how you're, you know, gauging, you know, how you're feeling, certainly against, you know, what population norms might be or something like that. And it gives you some guidance to say, you know, you should call now. Here's some online tools to use while you're waiting for an appointment, and so on and so forth. And I know, our own health services and counseling services is so well equipped that way. We have various tools that can be used in addition to one-on-one counseling and supports as ways we can support it. So it's, I certainly, if you've noticed any changes in your mood, feeling more negative versus more positive, changes in your behavior, things not working right, it's good to check in that way and have a checkup similar to that we do for our physical health.
Okay, thank you. We have time for 2 more questions, one for each of you. So Sherry, a question from the audience is, what measures have been taken by universities to lower suicide risk? You've talked about several things there as examples, but also what's been done to evaluate whether those interventions are effective or not? So.
Yeah, so at this point, a few things that have been done in terms of some of the recommendations from the Committee on Student Mental Health for our service has been to increase our amount of counselors that we have on campus. So after the Committee on Student Mental Health, I think we've been able to hire an additional 6 clinicians since that time. So that's been one of the things that we've been able to do, which just increases our access to students who are needing help. So in addition to the things that I spoke about, that would be one of them. Also looking at streamlining our crisis supports in our service as well. So currently we have one clinician who sees most of our students who are in crisis, and the way that that's improved our system is we used to have it dispersed across our team where somebody would come in and maybe see many people in our service. Now they're seeing probably 1 or 2 clinicians, so building that relationship and getting connected to supports as opposed to just kind of coming in and seeing many counselors. So those have been a couple changes that we've made.
Great, thank you. And I'll ask my team members on the COSM committee to also post a link in one of the chats for where people can see information about progress with respect to the implementation of recommendations. And Chris, a quick question for you. If you could give a little bit more detail about the approach to suicide risk appraisal and the data that Jerica showed. There was a request for a little bit more technical explanation.
Yeah. So it's a scale called the Severity of Self-Harm Scale that Dr. Hirdes has actually led the development of, and it's embedded within the Intri mental health tool that's used in all inpatient psychiatry settings. So it's a scale that's already embedded within a very comprehensive assessment. And what it does is it identifies risk on a number of factors. First and foremost, those warning signs I talked about, so self-harm ideation, having a history of suicide attempt, and then it further differentiates based on the severity of symptoms that someone may be experiencing related to depression, as well as related to other mental health conditions like psychosis. And then it brings in that corroborating piece as well around, does the person have family members who are also concerned for the person's, that the person is at risk for suicide as well. So it brings all of that information in and then uses a decision tree algorithm to differentiate different levels of risk based on the combinations of those kinds of symptoms. So again, warning signs, risk factors, and other corroborating information from the person.
Great, thank you very much, both of you, for excellent presentations. Very much appreciated. So now for folks in the audience, as you can see from this slide that's up, we're going to our live poster Q&A session. So you can use that link to get to the poster sessions and the breakout rooms for the poster sessions to interact with folks that have posted those. So that will go from 11:15 on for, I'll need to check my schedule for the next part. I think it's about 45 minutes if I recall. So do visit that. And then for the afternoon session, just know that you'll need to use a second link off of the Eventfy site You probably already have it in your email invite or in your calendar, but just know it's a different link from this morning's link. So make sure to use that and join us this afternoon. But do go to the poster sessions now. There's lots of folks there waiting to interact with you. Thank you very much.